Now, in the present climate, the saga of COVID-19 continues to be a nuisance. And the second wave of COVID is a reality in the United Kingdom. Yesterday, in the PM's office, they team briefed 7,000 new cases with 71 deaths. I believe 2,250 beds, NHS beds, occupied by COVID patients. Of those, 312 ventilated. Now, there is a problem with the non-COVID treatment as well. Nearly 1 million women missed breast cancer screening. Anxiety and depression among shielded group has doubled. The panic buying has set in. So what we do now? Let us listen to the experts. Now, today's expert is Professor A.V. Ramanan from Bristol. He's going to talk about pathology mainly, hyperinflammatory states in children and adults in COVID. And he will also touch upon the trials he has involved both in United Kingdom and India. Now, to introduce our speaker, I will invite his longtime friend, Ranga. Ranga is the CME secretary of our group. Over to you, Dr. Ranga.
Thank you, Dr. Raju. It gives me great pleasure to invite the MSMA and other groups to our CME. Professor Ramanan is as you said, is a close friend of mine. He done a lot of research. I won't take much of the time, but his research, and he is an academic professor in Bristol, and he works in the children's department in Bristol. He's attached to the Bristol Royal Hospital as well as the Bath Hospital, where there is a rheumatology and pain management center of excellence. And he does a lot of Royal College of Pediatrics and Child Health activities. I would say he's a presidential candidate for our Royal College of Pediatrics and Child Health, but it's a matter of time. He's still young. He's about, if you say Tamil and me are senior citizens, he is about 20 years younger to us. Right? So he's got a good innings. So I wish him all the best, and I invite him to start the CME talk. Thank you, Professor Ramanan, or Dr. Ram.
Thank you very much, Dr. Ranga, for that kind introduction. I'm not sure I'm half as worthy as you point out, but thank you. So just to give you a bit of background and a bit of context, I'm a pediatrician and specifically a pediatric rheumatologist. I have been doing a whole host of work in COVID-19, and I'll explain why. Over the last 10 years, I've been working closely on another infection which has never hit the shores of UK or the West, but is a huge problem in India, which is dengue. And in dengue, we know it's very similar to COVID in that quite a number of people are asymptomatic, and then a small minority get ill, and an even smaller minority get significantly unwell. So I've had an interest in the immune response to viral infections for about 15 years, which kind of is where I come from. I don't treat adults with COVID-19 hyperinflammatory syndromes, but I am involved in multiple trial initiatives, including in UK, US, and in India, and I'll explain that. It's always challenging because I know the audience is a mixed group of people with multiple specialities, so I make apologies in advance if I go into a bit of immunology. But normally when you go into the immunology of something, you might think if you're a urologist or if you're a GP, this has no relevance to me. But COVID is something which has relevance to every one of you because we all have friends and family in India, which is fairly at the epicenter of the pandemic, and then even here. So we must be, as physicians with extended families and friends, all asking us when they get ill. So it's worth knowing where the state of play is. So I'll first touch on the children, then I'll first touch on the adults, and then I'll finish off with some of the trials we've just finished in India. So when COVID first hit the shores of UK in March, April, the conventional wisdom was this was a fairly benign event in children, and the children are largely spared the ill effects of COVID. And I think that's still true in October 2020. We know in general, even in adults, the rule of thumb is 80% of the adults will get mild or minimal symptoms with COVID, 15% will need hospitalization roughly, and 5% will need intensive care. But this proportion is not true for kids. In kids, it's fairly minimal, if not completely asymptomatic. But then in April in London, we started seeing a series of children presenting very unwell to intensive care, mainly from Lambeth area, first to Guy's and St. Thomas's. So I was part of a small group put together by the Royal College of Pediatrics and the NHS England to come out with this guidance, which we call this multi-system inflammatory syndrome. At that time, we said temporarily associated with COVID-19 because we were very cautious not to assign causality because this was April. So what was this? This was a feature which shared some similarities with Kawasaki disease. It also, in some kids, looked like toxic shock syndrome or like bacterial sepsis. So we said in April, and that's still true in October, that when you have a child who presents either in your family or as a GP or as a pediatrician with persistent fever, and if you check simple laboratory tests, you will find a high CRP, a low lymphocyte count, and the low lymphocyte count is very similar to adult COVID. Low lymphocyte count in adult COVID is a kind of a classic feature of COVID-19 infection, and a high neutrophil count. And most of these kids were presenting with cardiac failure and hypotension, and significant numbers initially were needing intubation, ventilation, and even ECMO. And some of these children, if not lots of these children, will fulfill the criteria for another not so uncommon condition in children called Kawasaki disease. But it was important, and we set out in the RCPCH NHS England guidance that people must still think of sepsis. But what's fascinating in the last 6 months is bacterial sepsis and bacterial viral infections are virtually reduced significantly because kids are no longer, at least till September, not in school, not cohabiting or playing in playgrounds. And one of my colleagues in Chennai said they've never seen as little sepsis or bacterial pneumonia, such a reduced incidence as they have in the last 6 months, because in India, schools are still not open. So one of the positive effects, even though education is seriously hampered, and particularly in the underprivileged children, is that bacterial infections and viral infections are at their record low. In fact, this season in Chennai, dengue has really not been a huge problem, although it has been in Bangalore. But the most important feature in kids, unlike in adults, is they are PCR negative. So this in children is not an infectious event from COVID-19, it's a post-infectious event. And I'll touch on that immunology of that. So if you have a child who has persistent fever of more than 38.5, who presents with hypotension, and the most other important clinical finding is they'll all present with abdominal pain. In the last 6 months, more than 10 children in UK have had their abdomens opened up thinking they've got acute appendicitis, when what they have is a COVID-19 associated vasculitic presentation of abdominal pain. And so the surgeons from Great Ormond Street have actually published a paper on this showing the mimic of COVID-19 hyperinflammation in kids presenting as acute appendicitis. So there's a surgical message here as well. If you did the bloods, the key things you'll find is they'll have very high CRPs in the 200s or 300s. They'll have very high D-dimers. And the D-dimers is not a reflection of a coagulopathic state as it is in adults, but it's a reflection of the vascular endothelium being activated. So it's probably behaving like a vasculitis. They'll have a low lymphocyte count. If you were to do an echo, 2/3 of these kids will have reduced ejection fraction and myocarditis. Some of them will develop coronary artery lesions. Chest X-ray changes are minimal. So COVID-19 in children, unlike in adults, spares the lung. So it primarily involves the systemic circulation, gives you a presentation of abdominal pain, largely spares the lungs. And if you did an abdominal ultrasound, you will have features which will mimic appendicitis with colitis, ileitis. So this is the first 58 children, which was published in JAMA, which is kind of one of the pivotal papers from the UK experience of children. We now have close to 250 kids in UK, who have at least 250 kids who have presented like this. And what they found was the children are usually between the ages of 8 to 15. So these are not young children. These are slightly older children. And there may be good immunological reasons for that. We know that for the SARS-CoV-2 virus to take hold in your body, you need the ACE2 receptor, which is present in your nasal mucosa. Now, children have a low prevalence of ACE2 receptors in their nasal mucosa, which is one very significant reason why under 5 children seem to develop minimal, if hardly any symptoms. It's also another reason why seropositivity for PCR testing, or PCR testing, can be very falsely negative in a lot of young children. But look at this, the key is, in London at least, it seems to be disproportionately affecting Black and Asian minority ethnic individuals. Now this might be, we can speculate 2 reasons. One is it might be the genetics, which I don't think is the reason. It's more socioeconomic variables. We know that there is a greater low socioeconomic background in those of BAME background. They may live in housing, which means that loads more individuals live in close proximity to each other. And there are other variables which come into play in the excess mortality in BAME population in UK in adults, which is not in play in children. But there is certainly some level of obesity, even in the children, and low socioeconomic factors. What's interesting is virtually, I'll come to this, but every country in the world has reported this syndrome except China. Now, it might be from 2 reasons. One is probably information from China is hard to come by, which I don't think is true. I think it's more to do with the single child family policy of China over the 60s, 70s, and 80s. So it seems for children to develop this, you need repeat viral exposure. So it would be, you are at greater risk if you live in a household with multi-generational families, or multiple members, or greater sibling load, so that every time you have a viral load in one of the family members being affected, you get an immunological stimulus to the virus, which produces this hyperinflammatory syndrome, which might be a good explanation why this syndrome hasn't been seen in China, where really until a decade ago, you were only allowed to have 1 child. So the key clinical finding, as I've pointed out before, is abdominal pain, so much so it can mimic appendicitis. A fifth of these children will have acute kidney injury, which is usually hypovolemic in nature. But more importantly, half of them will present with hypotension needing inotropic support. So even though COVID is largely benign in kids, a very tiny proportion of children can present significantly unwell with hypotension and may even need intubation and ventilation, and we'll touch on that. Most of these kids did well, and we've had only 1 death in the UK, to my knowledge at least, did very well with just intravenous immunoglobulin. Why intravenous immunoglobulin? We were using it for Kawasaki, so we extrapolated and used it here. We don't know how it works, we don't know why it works, but we know it does work. And then 2/3 of the patients also got steroids. I think it would be more valuable if we can use steroids instead of immunoglobulin, because immunoglobulin is very expensive, particularly in developing country contexts like India, where you have to pay out of pocket for immunoglobulin, and each gram can cost a couple of thousand rupees. So if you're a 70 kilo, 15-year-old child, for example, then it's going to be a significant cost, particularly for those on the low socioeconomic strata. Coronary aneurysms, and this is a significant feature we have to follow up in the long run. It seems to behave like Kawasaki in giving hypotension and coronary aneurysms. And we don't know if some of these children in their 30s and 40s will get premature atherosclerosis and may have excess mortality from myocardial infarction. So some of the ill effects of COVID-19, we may have to wait for 20, 30 years to see what the impact is on that system. And this is really one of the key take-home messages. They will be PCR negative and more likely to be antibody positive. So when you see these children present with abdominal pain, high fever, high CRP, and you suspect COVID and you do a PCR, you're more likely to have the PCR negative. But if you add access to the antibody, which in UK we have universal access to the antibody now, you can get it back in a couple of hours. So it demonstrates that this is not an infectious event, but it's a post-infectious event. And if you did blood tests, what will you find? You'll find very low lymphocyte count, which I've highlighted here. Very high CRP. The mean CRP in these 58 children was 229. So we're not talking of mild elevations of CRP of 30, 40, or 50 that you would see in common cold or viral infections. You're talking in the hundreds and 200s. You will see an elevation of LDH, although this is not that helpful because it's not that high. And this is something which we haven't done in pediatrics a lot. It's done in adult medicine a lot, troponin and pro-BNP. They seem to be significantly elevated, suggesting again some coronary or vascular endothelial activation. And COVID-19 in children is behaving like a vasculitis. And the D-dimer is also suggesting vascular activation. The D-dimer is good as a predictor of how significantly inflamed you are, but it's not good in follow-up. So there's no point doing it repeatedly. It's good to do at once a diagnosis, but you don't have to repeat it again and again. And if you are doing this in the Indian context, each of this has to be paid out of pocket, which is significantly expensive. So if you're a pediatrician and you're listening to this and you think, how am I going to discriminate the COVID-19 associated inflammatory syndrome from Kawasaki or Kawasaki shock or toxic shock syndrome from Staphylococcus or Streptococcus? Age is a good marker. The Kawasaki patients tend to be 5 or under, as does the toxic shock patients. These patients have a mean age of about 8 or 9, but more classically present between 10 to 15 years. So they're usually adolescents. The lymphocyte count is a marker. Kawasaki patients and toxic shock syndrome patients don't have low lymphocyte counts, whereas the hyperinflammatory patients with COVID-19 will have a low lymphocyte count. The CRP elevation that you see in COVID-19 in children is far higher than you see in Kawasaki and toxic shock. So it'd be with a mean more than 200, which is fairly unusual in pediatric practice outside bacterial sepsis. Is this isolated to UK? No, this is the American experience. This is from the first report in NEJM, and they showed that a significant majority of their kids were coming in needing mechanical ventilation and even ECMO, managed with just steroids and immunoglobulin. This was the first report from Italy, which most of you know. Bergamo was the epicenter of the pandemic in Europe. And within a month, the Italians started seeing a string of these children presenting quite unwell. And across the border from Italy is France, and they also saw similar context, and they noted a lot of heart failure. So exactly the same that's been seen virtually every part of the world. And I'll show you the Indian experience, which we published as well. The French noted that the myocardial involvement, the myocardial stunning, and the damage as a significant feature. And that's been replicated in the British series, in the American series, and in the Italian series. So these are very sick children when they present, although it's a rare event, may need ventilatory support as well as circulatory support. But the reassuring bit is, if recognized early, managed appropriately, most of them get better with just immunoglobulin and steroids. So this is a nice picture that the French group put together. What is it that you get if you, the key ones I've put in red, you get a lot of gastrointestinal symptoms, abdominal pain being a key feature. You have fever for more than 4 days, usually more than 38.5. Myocarditis and pericarditis are the significant cardiac manifestations. Respiratory manifestations are very uncommon, which is a significant difference from adult COVID. Skin rashes, a whole host of rashes, including the COVID toes, the purple rashes that people have reported are all seen. So this is work we did in a hospital in Chennai. So sometime in April, we recognized that we're going to start seeing this. So I have a close association with a hospital in Chennai called Child's Trust Hospital. Some of you might know, some of you may not have heard. It's a not-for-profit children's hospital, which has been running since 1970s. And we looked at the first cohort of kids, and this was the first paper published in India of the hyperinflammatory syndrome associated with COVID. And what is the Indian experience? Again, in India, maybe the PCR positivity is a bit higher than the Western experience. They had about 25-30% being PCR positive, but most of them were serology positive. The other key feature was that 2/3 of patients in the Indian series were also presenting with cardiovascular symptoms, mainly hypotension. There have been quite a few deaths, although these have not been reported in the government hospitals, because we all know that the figure of mortality you get in India, you have to add another 1.5 times that mortality because of obfuscation of data or the lack of clarity of data. 2/3 of these patients need PICU admission. So it's not a benign condition when it presents. But most of them were managed on IVIG and steroids. And in this single institution report, which we published, we had no mortality, which is very reassuring. So I'm going to switch gears because most of you may not be pediatricians and you're thinking, okay, I've given up my Saturday morning join just because I might learn something about COVID. And this guy's rattling on about all sorts of things in kids. So let me contextualize it. Any of us being BAME are a high risk. So even if you have no interest in internal medicine, if you have no interest in immunology, I would listen carefully because it could be us, one of us or one of our loved ones. So what happens in COVID-19? Let's take a step back and look at the immunology. So when you get in contact with this virus, the SARS-CoV-2 virus, and let me point out at this time, I'm closely involved with folks who do the vaccine. To date, coronavirus has been a huge problem in animals, particularly in chicken. We've not been very successful in vaccines. Okay, so the vets have been trying to get a vaccine for coronaviruses for almost a decade. Of course, the efforts are multiplied now, but just to throw a bit of caution of what's going to happen in the vaccine studies. So when you get aerosol exposure to SARS-CoV-2 through the ACE2 receptors in the nasal mucus and then in the lung epithelium, you have the alveoli, which is rich. Now, there's some fascinating work, which I'm not going to show because it's going to go into deep science, but the type 1 interferon, which is a key way our human response to infections is, you are more likely to have severe COVID if you have a blunted type 1 interferon response. Now, there may be a host of reasons why those of us who are of Asian origin living in UK seem more susceptible, if that is really true, compared to our relatives who live in India who don't seem to be as affected. And I take a step back and point out to you that there are so many things which change when you have some people like us who in the first generation are moved from one continent to another. And we have what we call epigenetics, the effect of environment on genetics. And the best example of this is most of you who had kids or grandkids would know that the kids who grow up here have a high incidence of eczema and asthma. Okay, you can go to any Indian function or party, and I can guarantee you 2/3 of the kids there will have either asthma or eczema. And if you ask why that is, that's an area we know very well. When we are growing up in India, most of us did, parasitic exposure was a way of life. If you're not guaranteed 3 meals a day, you are still guaranteed a few parasites every day because we played in mud. And what the parasites does, it's what we call in the immune shift. Our kids growing up here are growing up in sanitized environments, as do the middle-class kids in India as well. So you have an immunological shift towards allergic diseases. So you'll have more of asthma and eczema. When we were studying in medical school in India, inflammatory bowel disease was virtually unknown. You go back now, there is a huge incidence of inflammatory bowel disease in India. Inflammatory bowel disease was something I only read in a book. I'd never seen a case, and I don't know how many of you have seen. Now, most of us will have friends or relatives with inflammatory bowel disease. So the effect of environment on the genetics, the South Asian in South Asia is very different to the South Asian in UK, just to contextualize this. And maybe some of us may have lost that power of the type 1 interferon response we had when we were continually battling infections back home. Now that we live in our cozy setups with radiators and all the modcons, we are only used to battling Western viruses. So maybe that's what makes us more susceptible. But what happens when the virus takes hold in the alveolar epithelium, and if you have a blunted type 1 interferon response, is you activate the cells which produce the cytokines. And remember, it's not the COVID viremia which kills you. It's your immune response to this virus which kills you. So in some ways, it's what you'd call an immune-mediated destruction of your body rather than a virus-mediated destruction of your body. What are the risk factors? We know that if you're above the age of 75, every decade you're older increases your risk. If you have a high neutrophil count, and it's no surprise that coagulopathy, which was reflected in high LDH and high D-dimer in adults at presentation, or presenting with multi-organ dysfunction are all risk factors. So we know that some of the severe cases really had high levels of cytokines, and that's the hyperinflammatory syndrome. So the virus, activates a key cytokine, which is interleukin-6, and we'll come back to this because it's a fascinating cytokine. It leads to what you see in simple labs such as CRP. Now, again, there's a huge myth in India. People go around checking IL-6 levels, which is complete nonsense because IL-6 level is not appropriate unless it's done in a very validated fashion. It's much better to just do CRP. CRP is a fantastic surrogate for IL-6. So you save money and you don't get spurious results of IL-6, which the same person at the same time in Chennai has had 2 different IL-6 values from 2 different labs, which just goes to show how variable cytokine measurement is. But CRP is a much more stable, reliable, leads to vascular endothelial activation, this IL-6. It activates a complement pathway, which is why people are looking at blocking complement in very severe patients as a means of making them better. This activation of complement and the vascular activation and endothelial activation leads to coagulopathy. So loads of those who die, when you do the postmortem of COVID-19 adults, you will see multiple thrombi in the lung, multiple microthrombi in the heart. So it seems that you can get a localized activation of inflammatory molecules being released in the lung and a localized coagulopathic process in the lung and in the heart. So we took this forward and we published this in May again, where we took a very sick child in Chennai and we said, okay, you're not getting better with immunoglobulin. Let's try an interleukin-6 blockade, Tolinizumab. So what I'm showing here is this boy, when he first presented, had a very high CRP, 318. He wasn't really getting that better post-IVIG. So we waited for 72 hours post-IVIG. And because he was still significantly ill and needing intubation, ventilation, cardiovascular support with inotropes, we decided we'd give him Tolinizumab, and with absolutely dramatic effect, and discharged 72 hours later. And that's just an anecdote. So let's come to where the world of research is in children, and then I'll touch on the world of research in adults. I'm only going to scratch the surface because there's so much happening. So most of you know that there's a recovery trial in adults which showed that steroids work. First thing to mention about steroids, the recovery trial showed that you should go on steroids only if you need oxygen. If you have COVID-19 and you are not on oxygen and you take steroids, you may have harm. Why is this important? Because there are loads of hospitals in India which give out steroids to anybody who comes in with COVID-19. The standard of care is so variable, and we all know this. So I'm part of the steering committee of the recovery trial in children, where we have tailored it to address some of the specific questions, because we don't see COVID-19 pneumonitis in kids. We see COVID-19 hyperinflammatory syndrome in kids. I'm part of the group which runs the British Pediatric Surveillance Unit, where every pediatrician in the country is asked to report. So we've so far collected 250 cases of hyperinflammatory syndrome in kids, and we're hoping to analyze that data in the next couple of weeks and publish it. And then we're the folks running biomarker studies as well, and I'm running one from Child Trust Hospital, where we've collected 500 patients, children. We've collected serial blood samples, and we're going to look at some key markers to see if we can identify a biological marker of which child is going to become very ill and which child is not going to become ill. So when we started the recovery trial in adults, we had the same plan in children, which was trying lopanavir, ritonavir, which now we know doesn't work. These are antiviral agents which was used in HIV medicine, and then steroids, which we now know works. Hydroxychloroquine, which we now know doesn't work. This is the recovery trial design as it was in April. And this is the adapted version for pediatrics, because that's the bit I'm involved in. And then if a patient has more than 75 of CRP, and if they are a child, if they have persistent fever, they get randomized to Tolinizumab. If they are an adult, they have to have oxygen requirement and a CRP of more than 75 to get randomized to Tolinizumab or no Tolinizumab. We have now changed the recovery trial since mid-September. Now the question we are trying to address in children is IVIG or steroids the right drug to give when children present with significant inflammatory syndrome associated with COVID? And we've kept the Tolinizumab arm the same. We know that steroids work, so we've taken that arm out. We know that lopanavir, ritonavir, Kaletra doesn't work, and we have taken away hydroxychloroquine. which again was being dished out and taken by loads of people in the absence of any evidence. For those who are very interested, we've just published this in the Lancet Child and Health. So we led a group of us, polled about 100 pediatricians across UK, and this was led by NHS England, although it was published through the college. And this is a national consensus management pathway, which we've just published on the 18th of September, so a couple of weeks ago. The full text paper is available online. So if someone wants to know about every investigation to do, how to manage da-da-da, please look this paper up and you can read at leisure. So to finish the first part of this talk of what is the key message, there is a new syndrome, although it's rare, in children associated with COVID, and it's seen in areas of high prevalence. So in UK, it's mainly seen in London and then in the Northeast and Northwest. In India, it's seen a lot in Chennai, in Mumbai, in Delhi, and slowly expanding to the other parts. Its presentation can mimic acute appendicitis. Simple blood tests are enough and they'll show a high CRP, low lymphocyte count, and high D-dimer. This combination is enough for you to suspect and diagnose this condition. PCR will be negative. If you can access serology, which if you live in UK, you can in a couple of hours. If you live in India, you can't, then the serology will be positive. How do you treat? Immunoglobulin plus aspirin, as you would do for Kawasaki. Or if the patient can't afford immunoglobulin or immunoglobulin is not available, then you can try IV methylprednisolone. This is a constant problem in some hospitals in India, because if you go to a private hospital and you haven't got access to much resources, then IVIG is expensive. So then IV methylpred is as good. Tocilizumab or interleukin-6 blockade is something that can be thought of in centers which have the expertise to manage this drug. But before you give immunoglobulin, particularly in developing countries, you must always take a serum sample so that at least in the future, you can look for the antibody test. Once you give IVIG, you can't test for COVID antibody status, because even if they are positive, it might be because they're positive from the pooled plasma that's been given through the IVIG from a donor. So let's look at what happens to COVID or our immune response. This is if you or I were to get COVID, you know, we would get a host of responses. If we are lucky, we'll have minimal or no symptoms, and that's mild COVID. If we are unlucky, we would have what we call as acute respiratory distress syndrome, which is just a description of severe lung injury, but also with significant cytokine storm, and that's the hyperinflammatory syndrome. And you can have people in the middle just needing a bit of oxygen and getting better. This group is almost always going to be intubated, ventilated, and have multi-organ failure and a lot of input. I'm making advance apologies, but what I'm trying to demonstrate, if you can't follow this, is the COVID-19 in a host will behave in multiple ways, and it depends on your immune response. And we have two types of immune response. One's called innate, which means that which is innate in you, which you don't need an external trigger. And adaptive is when you have an organism such as SARS-CoV-2 virus. What is unique about the SARS-CoV-2 virus is you have defects in both adaptive and in innate immunity, which explains why some 80-year-olds are walking away with minimal symptoms and some 50-year-olds are succumbing. So it's not a straightforward genetics issue, but it might be a host of other variables. And I won't linger long for this because it's not pleasant viewing on a Saturday morning. But let's come to something which is more straightforward. Let's look at what can you do having understood all of this. So if you were to block interleukin-6, and I've shown you a few pictures of why interleukin-6 might be a key cytokine, maybe we can reduce mortality and reduce the lung inflammation, because interleukin-6 will increase mortality because it delays healing, it causes pulmonary fibrosis, which is why you hear reports of people who are recovering from COVID having reduced lung capacity, and it causes decreased phagocytosis. So it's a promising thought that maybe blocking interleukin-6 might be a very effective tool for managing this condition. So how can you block interleukin-6? There are a host of molecules. There's one called Tolinizumab, there's one called Sarilumab, and one called Tocilizumab. Now, there have been a host of studies which have put out press releases, some saying they haven't worked, some saying they have worked. And that's because of the way they've chosen the patients. So stratification of the patient population is a huge problem in most of these trials. And the recovery tocilizumab data is not out yet. But what I'm demonstrating here is there are 3 molecules which can be used to block interleukin-6. So I led a small group with Medanta Institute of Education and Research, which is in India, which was founded by Naresh Trehan. So Naresh Trehan is the head of this institution. But Avi Soin, Dr. Avinda Soin, is the principal investigator, and I'm part of the group of the steering committee. So we set out to do a multi-center randomized phase 3 study as an investigator-initiated study to look at tocilizumab plus standard of care versus just standard of care in India. So the setting was India. It was in COVID-19 positive patients, and our aim was to recruit 180 patients. 90 were going to be randomized to tocilizumab plus standard of care, and 90 to just standard of care. We thought the study will take 7 months. We finished in 8 weeks. And the study was run mainly in private hospitals, and I'll show you which hospitals because of a host of difficulties in getting approvals and the time taken. So what was our primary objective? Our primary objective was to see if tocilizumab in a stratified patient population might help outcomes for COVID-19 associated moderate or severe disease. So we looked at a whole host of, we graded the COVID-19 infection, looked at time to improvement. We were going to look at the number of patients who needed mechanical ventilation. We were going to look at ventilator-free days, organ-free failure days, duration of stay in intensive care, and we will, of course, look at the safety of this agent. The primary endpoint is very simple. It's looking at day 28 and day 14, number of patients alive or dead, and mortality. But I think the secondary endpoints are going to be as important, which is how many patients were we able to avoid admission to the intensive care or needing ventilation. So this is the picture. We take a COVID-19 positive patient who meets the criteria, they get randomized, and then they will get either tocilizumab plus standard of care or standard of care post-randomization. We've completed the study. The last patient was recruited on the 31st of August. That patient's 28-day visit will be the last week of September, which is completed. We're hoping to have the data ready by the 15th of October, and then hopefully to write the paper in the next couple of weeks and submit it to probably a high impact factor journal, because it's the first and only randomized controlled trial of this nature done in India in real time. So most of the hospitals, as you can see, are private hospitals, apart from PGIMS Chandigarh and SGPGI Lucknow. There is also Apollo Chennai, which recruited 15 patients. For those of you who, because this is a Madras State Medical Association, that's a hospital you might all recognize. I'm going to finish with this slide. You know, these days, no talk is complete, no work is complete without our AI and computer guys getting involved. So this was a group from a company called Benevolent AI made a projection that a drug which I'm doing multiple trials with called Baricitinib, which is used in juvenile arthritis, adult psoriasis, might actually have a role in COVID-19. And lo and behold, immediately the Italians published a study showing that if you give Baricitinib plus standard of care versus just standard of care, you had a much better outcome in terms of ICU admission and mortality. So it seems to be a good drug. So I'm involved with this company which makes Baricitinib, which is Eli Lilly, in a large randomized controlled trial, which is going to be a 600-patient study, which we're recruiting across US and Latin America, and we're hoping we can even take it to India. So lots of exciting stuff happening, although we are only making very tiny steps. I'll stop there and take any questions. Thank you.
And thanks for everybody. Thanks, Professor Ramanan.
Thank you.
Bye-bye.